Hello, my name's Paul Davis. I'm a Senior Clinical Audit Facilitator with the National Comparative Audit of Blood Transfusion. I'm here today with my colleague, John Grant Casey. John, if you'd like to introduce yourself.
Good morning, Paul. Good morning, everybody. My name is John Grant Casey, and I'm the Program Manager for the National Comparative Audit of Blood Transfusion.
Uh, and today I'm going to be talking to John, and we're just going to be talking about and discussing what the National Comparative Audit Programme is. So, first of all, John, can you tell me what is clinical audit?
Well, clinical audit, Paul, differs from research, which many people know about, because clinical audit is a way of measuring whether healthcare professionals are doing the kind of things that we expect them to do. So normally there are guidelines or things similar to that which are published, which set out the kind of behaviors we expect the healthcare professional to do. For example, a nurse taking a blood pressure reading or a doctor prescribing a certain medication in certain circumstances. So clinical audit starts by people setting out what behaviors we expect. And then in the clinical audit, we design means of collecting data which enables us to see whether people are executing the kind of behaviors we want. And then we feed that back. So, whereas research will talk about how you might add new knowledge. What happens if we do so and so? Clinical audit will simply say, is that person, that healthcare professional, doing the kind of things we expect them to do according to the guidance?
Wonderful. So, obviously, rather than National Clinical Audit, we're National Comparative Audit. So, what's National Comparative Audit? How are we different to just regular clinical audit?
Well, national comparative audits involve maybe all of the NHS trusts and the independent sector hospitals in the United Kingdom, and can often involve hospitals from other countries as well. And so, national, therefore, can mean we get a very wide participation. And frequently, Paul, in our programs, we get up to 87, maybe 90% of all the trusts in the NHS participating. And comparative means, of course, that when we issue a report to trusts, they could look at the national results, but they can also compare that with their own local results to see how they are doing compared with their peers. A very important thing to decide if you need to take action. So, the National Comparative Audit is a program that anybody and everybody can participate in if they do the kind of things we're auditing, but it allows them to benchmark themselves against their peers and against the national results.
Well, so that's sort of broad principles of what National Comparative Audit is. So, what exactly do we do then? What sort of things do we look at with the National Comparative Audit?
Well, first of all, Paul, the National Comparative Audit is not funded like any other national audit programs by the government's Healthcare Quality Improvement Partnership. We're funded directly by NHS Blood and Transplants. So we tend to focus only on issues that relate to the blood supply. And really, Paul, the job of the NCA is to protect the blood supply in many ways. And we do that by doing these clinical audits and being able to feed back to doctors on whether or not their transfusion decisions are appropriate in terms of should somebody have got that blood product or should somebody have got the quantity of blood product that they were given. So what we do then is we look at various concerns that we may have within the blood transfusion field. Is a product being used appropriately? Are people being managed? People will be well aware, Paul, of something called patient blood management that came in a while ago to the UK. And these are measures which people can do to prevent the person having a transfusion. And may I just come on to why do we want to do that? Well, two reasons. One is that we want to prevent the very, very theoretical risk of a transfusion transmitted infection occurring. It's been known to happen in the past. We avoid that. And of course, a blood transfusion is an invasive procedure, and anything that avoids invasion is good because that too carries an inherent infection control risk. So it really improves the patient care and patient safety if we can get the people to avoid the transfusion. And then coming on to the other side of what we do in the NCA there to protect the blood supply, We don't have a huge amount of blood that's available. Not that many people in the UK give blood. And therefore, we should be very, very careful that we can protect the blood supply by making sure that patients are not transfused unnecessarily. And a little known fact, Paul, is the fact that if we have a blood donor who goes into a hospital and that blood donor is transfused, then we won't be able to use the blood from that donor in future, because we can't identify all the transfusion transmitted infection risks that we need to. Therefore, we have to stand that donor down. And when we're already sometimes struggling to maintain good donor levels, what we don't want to do is to lose donors if we can help it. So it's what we do then is we identify areas of practice that might be amenable to avoiding transfusion. Then we go back to the standard clinical audit way of thinking. We look at what the guidelines currently say, and then we devise an audit which is based on those guidelines. But the great thing, Paul, about our program is that we have access to most of the national and international expertise on better blood transfusion practice. And that means, therefore, if there aren't any published guidelines, for example, we did an audit a while ago in 2018 on the management of people with massive hemorrhage, because there actually is no UK nor international definition of what a major hemorrhage is. And therefore, there's a wide variety of practice. So we needed to do a clinical audit based on what the criteria was for good. And because we have this national and international expertise, we were able to come to some sort of consensus on what good looks like. So therefore, instead of having a guideline or a publication, we had that consensus statement on better practice, and we were able to audit against that, which really goes on to a sort of a higher level, if you like, with the NCA, because as I've said, 87, 88% of trusts, sometimes we have as many as 8, 9, even 10,000 patients in our audits. With that level of data, and with that number of sites participating, it's pretty good, pretty
Mm.
robust data. And in the case of the major hemorrhage protocol audit, that data is so good, Paul, that we're able to influence future guideline writing, because we have evidence bases there which would normally be derived from randomized control trials or similar studies, but the audit can do that. So in brief, then, we look at what concerns there is to the blood supply at the moment, how we can conserve it, how we can avoid the unnecessary transfusion by knowing where the blood is going. We know already from our own internal mechanisms what blood is or what blood products are being consumed. And we say, can we target that to bring down blood use in, shall we say, orthopedic surgery? So that's the whole premise of what the NCA exists for.
Wonderful. Um, so then you've told me what we're doing with that data. How are we actually getting that data out there then? How is it used? Do we just put regular reports out, or is there more to it than that?
So what we do is we do audits probably twice, or if not three times a year. And unlike other comparative audit programs where they have a continuing theme and the same topic, so you can get year on year comparative data, we don't tend to do that. We tend to do a repeat audit if and when needed, but otherwise we will do a different topic every year, or two different topics every year. And so we have a steering group which consists of all the medical royal colleges, the various societies and associations, and our sister blood services in Wales, Scotland, and Northern Ireland. And we get together once a year and we decide what is best to audit. And then, as I say, we then assemble an audit program from there.
Wonderful. And I think you've touched on this already briefly, John, but just how big is the National Comparative Audit Program? What sort of size of data set do we have?
Yeah, so we can run into huge data sets. Our biggest data set for one audit of patient blood management in people undergoing elective surgery had 9,200 patients. And the one we're currently working on, which we'll talk about in another video, Paul, we currently have between 6,000 and 7,000 patients on here. And one I'm especially proud of, again, which will be the subject of a future discussion, is we have every single type of operation for a particular patient group in the entire country for one whole year. And the great thing about that, and what's really makes this a great program to be involved in, is that we, for a long time now, have had not only the biggest data sets, but also the only data sets in the history of medicine. And that makes it a real privilege to work out. When we go internationally as well as we have, we've been auditing the same topic in the UK, in Europe, and sometimes in Australia and New Zealand. Now, when you get to that level of data, you've got a really, really
Mm.
representative sample which can change. And so it's great not only to be able to feed back to our local hospitals here in the UK and say, this is how you can make it better. But we're a pretty sophisticated blood service system in the UK. In certain parts of Europe and Africa and the Far East and the Middle East, they don't have that level of sophistication. So be able to get that big that we can give data to those countries, data they can believe in because of the size, it's pretty good. So we can become a massive program. And people have said in the past, and I think it's true, Paul, it's the biggest clinical audit of blood transfusion program on the planet.
Well, it sounds very exciting, John. Obviously, I'm paid to say that, but hopefully everyone else is excited about it too now.
Yeah.
If people want to take part in the program, then how can they take part?
It's very easy, really. Well, the best thing they could do is to either contact myself or contact you. Now, the thing is, while we do all of this fabulous work, there aren't actually that many people in the team, and those people watching the video will be seeing the entire team that's sitting on in front of our cameras. So they're just the two of us. Now, that actually is very, very good, Paul, because what it's meant, and by the way, we've been doing this audit now for just over a quarter of a century. What that means is that we are extremely lean in the way we operate things, and so there's very, very little bureaucracy. So if anybody wants to take part in an audit, they can email us, they can phone us and say, I want to take part in this. And normally, because it's electronic based, we have our own website and we set people up. Normally, Paul, if people express an interest, then within 10 minutes of that initial call, they can be online and they can be contributing data. It's a simple matter of just calling us or emailing us. Now, the important thing that people to realize here it too is that we've embraced all levels of working, and so we are very diverse. So we have the very low tech a way of collecting data, which is where we print an audit booklet or a pro forma. We send those out to hospitals with instructions. All they need is a pencil, and then they fill the booklets in and they return them to us, and we do all the rest, all the processing. And that is entirely free. There's no charge to participate in the program, and there's no charge to send the booklets back to us. That's the low tech end, and many, many people do rely upon that system, and we're glad of it. The high tech end is that our system is set up so that you can do everything from a mobile phone from one of these. So you can log on to your online page, you can enter data, and as we refine the system, you can download your own data and look at the reports as well. So that's how you join the program. And the great thing to remember is that you can access it electronically on the end of a mobile phone on any device connected to the internet. And a really important thing for people, Paul, thinking about is it worthwhile participating, is that don't have any minimum sample sizes. Now, many comparative audit programs will want X number of patients. We don't. And the simple reason for that, Paul, is the fact that if we're going to audit how well people with an hematological condition are managed, then we don't know how many people will be coming in July or August. And therefore, we say to somebody, yeah, do please participate. There is no minimum sample. And so therefore, if you've only seen 10 patients in the last 3 months, give us that data. Because actually, that's 100% of your sample, which really gives us very high quality data.
Wonderful. Well, Thank you very much for your time today, John. Hopefully, everyone watching has learned a little bit more now about what the National Comparative Audit Programme is, and we should hopefully be working with them in the future.
I hope so, Paul. Thanks very much.
Wonderful. Thank you, John.